Hello, my name is Chris Cagnon. I'm from UCLA Medical Center, and today I'm going to be discussing orders versus protocols when technologists question the physician. Next. So what's at issue? Most of the audience here is well aware that the use of CT as a diagnostic tool has seen tremendous growth over the last 2 decades. Annual number of CT exams in the U.S. has grown from 3 million in 1980 to an estimated 62 million by the mid-2000s. Further, the number of pediatric emergency department visits that included a CT increased 5-fold from 1995 to 2008. The NCRP tells us that radiation dose from CT now comprises 1/4 of the population's total radiation exposure and half of its medical exposure. Next. What's at issue? Well, recently, well-publicized CT incidents have resulted in congressional hearings, class action lawsuits against multiple hospitals and vendors, considerable media attention, and even state regulations that specifically address CT have been introduced and passed, specific California Senate Bill 1237. Some of the discussion around these incidents has involved the technologist's roles and responsibilities, and primarily things behind the scan protocols: who designed them, who implemented them, who adjust them, who can make adjustments on the fly. Next. The FDA has gotten in the picture with their initiative to reduce unnecessary radiation exposure from medical imaging. They talk about informed clinical decision, safeguards to scanner design, increased patient awareness. The Joint Commission has also gotten in the picture with their Sentinel Event Alert. And of course, Medicare and Medicaid Services has required the accreditation of CT facilities for non-hospital as of January of this year. And California now requires that all CT be accredited by July 2012. Next. What were the recommendations to the healthcare providers? There was discussion about investigating for potential injuries, and I want to stress this point: reviewing CT protocols and implementing QC procedures. They discussed the need to adjust for appropriate dose, patient size dose, dose specific for the task, and be familiar with the dose indices. Some of these dose indices that are now showing on the scanner weren't even visible 3 or 4 years ago. There were recommendations made to the public. Certainly amongst them was consulting with your physician. And in fact, many patients now recall to request doses. They want to know their lifetime dose, and they keep track of this over their lifetime. And it's in fact even an iPhone app. Next. What has been the professional response? Well, the American College of Radiology, the AAPM, which is the American Association of Physicists in Medicine, amongst others, discussed the over-reliance on automation. They discussed the need to review and consider appropriate dose reference levels for CT, the importance of accreditation, and again, we're going to stress this here, the need for protocol review by a radiologist, a technologist, and hopefully a physicist. They quite correctly point out the need to enable dose reporting functions in all the scanners. As I said, some of these earlier scanners didn't even have the display of CTDI or CTDLP. They discussed the need for CT-specific training for all parties involved with the both the prescription and diagnosis of reading CT scans. Most of these societies have issued position statements in response to the media stories on the increase in medical radiation utilization, cancer risk, overdoses, and accidents. Next. So what's been some of the ideas behind the root cause of some of the incidents we've seen with CT? Well, certainly a lack of protocol standardization and or poor understanding of protocols and equipment capabilities was likely a contributing factor to some of these incidents. There was congressional testimony by experts from the ACR, AAPM, and the ASRT, and some of these discussions involved who actually has oversight. So if CT technologists irradiate the patient, what in fact do they actually use as an imaging protocol? And as most of us know, the imaging protocols can be quite varied amongst different scanners, even for a certain scanner, depending on the body parts and the clinical needs. Of course, radiologists ultimately determine the CT use, but there's actually fairly a few guidelines available. One of these can be seen at the ACR, look under the ACR practice guidelines. Which brings us back to the question of who designs and who implements the scan protocols and for what clinical indication. We've seen that there's significant potential for practice variation, both within institutions and across institutions, and even across CT scanner platforms, and even actually amongst a single make and model of CT scanner. And there'll be several talks at this symposium discussing just that issue. Next. Continuing on some of these root causes, I would suggest that while there's been considerable concern over scanner calibration, it appears that the majority of the events publicized in the media are in fact the result of operator error and or poor understanding or implementation of CT scanning protocols or supervision of how the CT is used. Next. CT scanners are technically complex. Their technology is constantly evolving. New software packages are being added on a biannual basis, even to a given scanner platform. Scan protocols are comprised of a host of technical factors that impact both patient dose and image quality. Scan protocols are, in fact, task-specific. They can vary amongst the different vendors and even across scan platforms for a given vendor. In other words, what protocol might work on a Siemens Sensation 16 may not be appropriate on a Siemens Sensation 64. Next. Experience and training with one single scanner does not mean proficiency with another, even of the same manufacturer. So as we introduce new scan platforms or even new software versions, we believe it's important that the technologists be trained on these specific platforms. Next. So who controls the protocols then? Well, the radiologists are in fact the responsible party. They read the CT images, yet they frequently have fairly limited technical knowledge and expertise with the actual equipment. Physicists, if you're lucky enough to have a physicist, they're generally highly educated and trained and focus on equipment calibration and characterization, but probably have little involvement in the actual clinical scan protocols and even poor understanding of actual clinical questions that are trying to be answered with these CT scans. As we said, the equipment is rapidly evolving. There's multiple scanner and technical variables that may be involved, and they're not always well standardized or understood. The technologist is the individual who usually actually radiates the patient. They usually implement the scan protocols and probably have the most vendor training, but they may not always have the most knowledge about the physics or the technical principles involved. Next. So let's discuss a little bit about the actual significance of the CT scan protocol itself. I would point out that CT equipment output in calibration in terms of radiation output, consistency, reproducibility, etc., is probably routinely evaluated. This may be required by regulations, CT accreditation, or even just general physics practice at your institution. The scanners themselves, though, are generally very, very stable. The CT console, further I'd say that the CT console, their reported dose metrics in terms of CTDI and DLP is actually very, very accurate, and in our experience has been very consistent. It is actually important to remember that the actual technical factors that are specified in the scan protocols that directly control the machine output, the delivered radiation dose delivered, and the image quality. And yet it's these scan protocols themselves that are myriad, vendor-specific, highly variable, they're not regulated, and they have the most impact on patient dose. So in other words, it's not the calibration of the CT scanner that's the issue. It's the protocols that are used, the selection of KV, MA, pitch, collimation, that impact patient dose and image quality and can vary tremendously even within a single scanner type. Next. So who's ultimately responsible? We should remember that it's the FDA, the Food and Drug Administration, they regulate the equipment design and the features of the equipment. So if a vendor wants to bring a new CT scanner to market, they have to get FDA clearance for that design and those particular features. However, it's the state that typically regulates the equipment use and the users of the equipment. This leads to discussions about licensure of the physician and licensure of the CT technologist. For instance, in California, the radiologist is ultimately responsible for all the imaging being performed. They are able to do this through their California supervisor and operator permit. So they can both operate the machine, which is of course very rare, and of course they supervise the operators of the machine. In other words, they supervise the technologist. The radiologist reads the images and they bill for the exam. And ultimately, they're responsible for determining what protocols are used on the patients. Note that a technologist can only operate under the supervision of a physician, certainly in California. The vendor, however, generally has the most experience with the CT scanner, but they're ultimately not responsible for the patient. So if you're using vendor protocols, are they in fact preloaded standard protocols the vendor has? Have you introduced additional protocols? And what about machines that actually aren't under a vendor contract? Who's helping them or assisting them in terms of what kind of protocols they may be using on their patients? Next. How about the technologist's specific responsibility? Well, here's some information that I gleaned from the ASRT practice guidelines. The CT technologist performs CT procedures at the request of and for interpretation by a licensed independent practitioner. And I'll just race through the rest of these very quickly. They assist with interventional and therapeutic procedures. They perform fusion procedures. They exercise professional and ethical judgment. They have to demonstrate knowledge of anatomy, physiology, pathology, patient care, computer technology, radiation physics, and radiation biology protection. They have to understand positioning, exposure techniques, and scan protocols. And they administer and document medications and radiation exposure according to regulation or policy. So kind of common sense, not particularly helpful. Next. Further, the practice guidelines say that CT technologists are the primary liaison between patients, the licensed independent practitioners, and the support team, whatever that exactly means. The scope of practice in the ASRT guidelines says that the CT technologist applies ALARA, that stands for as low as reasonably achievable, principles to minimize exposure to patient and self, and, I think this is the important one here, they perform CT procedures as prescribed by a licensed independent practitioner. So again, the radiologist, who is the MD is the independent practitioner, licensed of course. The radiologist may not understand the protocols. The CT technologist is probably the one who programmed the protocols, but is in fact the radiologist who's ultimately responsible. Next. So what are some of the challenges that our technologists run into? Well, ordering the appropriate exam. Let's say the referring physician wants to have a certain type of exam or specific diagnostic information. What happens if the incorrect exam is ordered? Well, it results in a compromised diagnosis and probably insurance reimbursement problems. Who helps the ordering physician or the referring physician understand what kind of exams to order? Is there any kind of education? Does the radiologist in fact talk to them? Is there a reference manual they can consult to understand what kind of exams are offered by an institution? It should also be remembered that in our current economy, that radiologists may be RVU driven. This is a metric of their clinical productivity. So they may not always have the best motivation to spend time interacting with or educating referring physicians. What this ultimately results in is the technologists maybe end up moderating or caught in the middle between the referring physician and the radiologist. Another challenge is, what about new imaging techniques that we're all eager to use and prescribe to our patients? An example would say be CT cardiac perfusion. It may be available on the scanner, but there may not be billing codes yet available. More on the Technologist Dilemma, and some of these paradigms I'm going to discuss will obviously differ depending on what type of institution you're from, what your local structure, and of course your workflow. So what happens when the MD does order the incorrect study? So the example, of course, is the requested study doesn't match the actual clinical indication, and this generally would impact reimbursement. The result is you often have patient and scanner delays incurred by the necessity of contacting and resolving with the requesting MD, having the incorrect order canceled and the correct order placed. This becomes even more difficult if the referring MD is actually off service and the covering MD has to be brought in to address the question. We see all kinds of examples of insurance workarounds where you're ordering one kind of exam that might be reimbursed when you're actually, the requesting physician wants another type. There's the challenges of trying to get an additional effort needed to get requested data when not part of the actual requested protocol. So you're looking at certain kind of anatomy, you might need to order additional series or reformats or end up scanning additional anatomy if in fact the information you're trying to see is not part of the default clinical protocol. Next. Some examples of this. Let's say the MD orders CT and obtains authorization, but the indication for the CT calls for a CT angio. Well, the requesting MD needs to be contacted for revision of the order and authorization, which can be time-consuming. If the authorization is not immediately possible, then this also becomes a patient dilemma. In other words, do they proceed with the imaging and risk denial of payment if it's not reimbursed by the insurance company? Or do they postpone and reschedule the appointment, and perhaps they've come from far away, or in fact, maybe they've already even started drinking their contrast, etc. These are all can in fact be real-life challenges that we face every day. Next. We should also consider the challenges of the inpatient versus the outpatient environment. In the inpatient environment, it's probably not going to be too long now before we see that payments are capped. This is all part of the Obamacare efforts that would argue that new healthcare regulations may require payment based on outcomes rather than the actual exams ordered. So what exams are ordered by the hospital is up to them, but they're only going to get actually a fixed payment. The outpatient environment is probably going to be different. And of course, the technologist and the physician has to determine is the actual ordered exam covered or reimbursed by insurance. What alternatives may be available when requested? And if it's not covered by insurance, could you offer it for a cash payment? This actually, of course, drives home the point is that you should have a good relationship between the referring physician and the radiologist so they can, in fact, determine what is the appropriate exam. Is it going to be paid for? Does it need to be modified? Things like that. What about some of the workarounds we see? Well, here's another example. Let's say the MD ordering the exam is interested in the coronary arteries, but insurance doesn't approve for that exam. So instead, the MD orders a CTA chest, CT angio chest, but in fact works with the radiologist in the background to obtain the information they want regarding the coronary arteries. Another workaround, certainly at a large institution, you might see where head and neck surgeons often use image navigation devices, say for radiotherapy, things like this. So let's say you order a CT sinus for a sinus surgery, it's approved by insurance, but in fact, to get the entire navigation device, the frame around the patient, you have to do full skull imaging. In order to get the proper information so you can do get the image navigation device to function. So in fact, the technologist has to increase the scan extent, say up to the top of the head, in order to capture the localization frame. So this is again a modification of an ordered protocol. Other additional challenges, as we mentioned earlier, the technology is rapidly changing. New software versions may be introduced on an annual, biannual basis, which in fact changes the graphic user interface, changes some of the features that the scanner may be capable of. Certainly recent events that we've seen have accelerated the vendors' efforts to introduce new technology, and certainly there's been a lot of focus on dose-saving strategies. All these software upgrades and features require training by the technologist, hopefully by the radiologist as well. These technologies can actually be difficult to implement without careful review and understanding by all participants. And if they're implemented or used incorrectly, they can actually adversely impact patient care. And we've seen, I think, some examples of that potentially with some of the recent incidents. Further, if you're a teaching institution, who's in fact making the call? If you're having a resident who's on call, they may not have the experience and may in fact rely on the technologist to determine what protocols should be used, which brings up the question, is there an attending radiologist specialist available to resolve problems and resolve questions? Next. So what are some strategies we can use to minimize these problems? I think one of the most important ones, of course, is protocol standardization. And the theory behind that is you minimize guesswork. You start off by having a clear and specific clinical indication to determine what kind of scan to use, and these clinical indications should be available to the referring physician. The protocols should be size, age, and condition specific where appropriate. All the technical and clinical management factors should be available, and they should be detailed. You could use pictures, drawings, schematics, what the scan extent should be, things like that. There should be a CT team of the specialist radiologist, say the neuro radiologist or musculoskeletal radiologist, a protocol technologist, and a physicist who helps develop protocols for each subspecialty. Something that's been suggested by some of our technologists is on an outpatient basis, they found it very easy to screen the work schedule and saves valuable time when actually bringing the patients to the scanner. And what this has entailed is having a dedicated individual, say a technologist, and this in fact may be a full-time FTE depending on the size of your institution, and they use the clinical indications specified on the protocols to review the schedule and then guide the referring physician, if necessary, have orders revised, and do pre-authorization of the cases. And this could occur up to 2 days in advance. Next. You should have periodic protocol review that results in a documented set of scan protocols, and these scan protocols should be harmonized on each scanner. In other words, if you have 4 or 5 scanners of the same make and model, they should all have the same scan protocols. They have to be adapted appropriately if the scanner make and model is different. Say, again, adapting from an 8-slice scanner to a 64-slice scanner, considering pitch and collimation. Each protocol, again, should have clear and specific clinical indications, and they, in fact, should be signed off by the radiologist. If the radiologist is, in fact, responsible, they should be aware of what the protocols are that are being used in their department. And I recommend having a physicist, if they're available, also sign up on the protocols because they can look at things like dose and some of the actual configurations of collimation, et cetera, and possibly provide some valuable information. We recommend that you have a lead technologist, maybe this is a QC or a protocol technologist, who's responsible for the protocols and implementation of them on the scanners. This may be more logical for a large institution, but instead of having multiple players, you have one person responsible for, again, implementing the protocols. There should be clear and defined processes for delineating responsibility and resolving problems with protocols. Next. You should consider how your protocols are currently vetted. You may just have start off with default vendor installed protocols, and again, as we said, they have the most experience. We're starting to see more dose check and dose tracking software, which is putting more accountability in the institution. You're having dose alerts show up on the scanners. We note that at our institution, protocols can change fairly frequently, and they can even were differing across identical scan platforms. So that requires some effort to harmonize. We ask the question all the time: were the protocols modified or added? In other words, were we using, say, an old GE protocol and now we're using a Toshiba scanner? Was the old protocol adapted for the new scanner? And if they were adapted, by whom and for what reason? So we have to ask ourselves, are they appropriate for the scanner they're installed on? Are they harmonized across similar scanners and or adapted to other scanner types? We found versions of scan protocols existed on paper, in notebooks. Some were programmed differently on the scanners. That were in various spreadsheets and databases. So we had a lot of work going on, but we spent a considerable effort to make sure they were all standardized, and we found that shared templates are very helpful. Next. Consider having a protocol team, and of course, this is a shared responsibility. That's the way things should work. Obviously, the physician and radiologist is ultimately responsible, so they should assign the team and the responsibilities. They certainly would be responsible for determining what the scan appropriateness criteria is. And if you're a large institution, you may have subspecialists, again, responsible for their respective sections. Neuro, chest, etc., abdomen. The technologist, you may have specialty technologists who have a specific assigned role. Protocol technologists, for instance. They're probably the ones who are most familiar with the scanner, and they're the person who programs the protocols in the scanner. And of course, if you have different scanner types, you have to make sure they're familiar with the different makes and models and how to program and how the technology works on the different scanner platforms. They're probably also the only team member who's probably received vendor-specific training or applications training, as we say. We recommend, whenever possible, you get a medical physicist involved. They generally have the best understanding of the scanner functions and the scanner technology, the technical factors, and how those technical factors influence the image quality and the dose. And they can translate these protocols to, in fact, other scanners. They're often usually knowledgeable regarding the reference standards in terms of dose and what's going on in the literature. Next. So we'll end up with a brief process steps for developing, harmonizing, and implementing and documenting protocols. And again, the motive here is to mitigate problems between the technologist, the radiologist, and the referring physician. So first off, identify and document a team and their responsibilities. Segregate the protocol types by subspecialty, body region, scanner model. Again, this will depend on the size of your institution, how you're structured. Certainly determine and document the clinical indications for each protocol. Establish and standardize anatomical positioning, the scan extents, the scan length, etc., the type of scan, helical or axial, and use pictures where appropriate. If you want to say image to the carina or start with the carina, then you can use an anatomical picture, PHI removed, of course. Determine the appropriate technical factors. This includes, of course, KV, MA, scan rotation time, the total collimation, pitch, the reconstruction slice thickness, and the kernel used. And if you're going to change these, make sure you understand the rationale for changing. Document the scanner reported dose values. I think we're going to find that all scanners now report CTDI and DLP. These should be included in the patient protocol charts. We understand they'll change with depending on patient size, but the standard values should be recorded, and the staff should understand that they're only a metric. They do not reflect true patient dose. Implement appropriate dose action level thresholds. We're seeing all new scanners be installed with software which will alert the user when certain dose thresholds have been exceeded. Next. Don't forget to include contrast administration and image processing information materials in your protocols. Make sure you can evaluate your protocols for dose reduction opportunities and image quality, and this is probably going to be an iterative process. You may look at where you're at, say, okay, we can go back down a bit, we'll dial it down 20%, we'll come back and reevaluate. As we said before, make sure you adapt and modify your protocols to your scanner's specific abilities and your scanner's specific limitations. Make sure you harmonize those protocols within the scanner type, so all scanners of the same type have the same protocols, and you can modify them to be appropriate for other scanner models. Include sign-off signatures. If you're going to go to the work of developing these protocols, make sure you have the radiologist, certainly in each section, sign off on those protocols. And please remember, things will and they should, in fact, change. Implement a change control process. In other words, if you're going to have revisions, who reviews them, who signs off on them, and ultimately, who has access to actually programming the scanner. And with this, we'll finish, and I thank you for your attention.